Hey, Kevin.
Happy Monday morning, Martin.
Happy Monday. So, Kevin, I'm curious. I previewed this a little bit on LinkedIn, and I said you were going to be sharing a controversial and brave opinion about what people need to give up to make American healthcare better. And so here I am teeing you up. What is it? What do we got to give up?
I did see that on LinkedIn. I spent a lot of time this weekend trying to figure out how I was going to answer that question in a thoughtful way. I will tee it up first. Zeke Emanuel shared a article in Bulwark last week that did a really good job, I thought, unpacking this question, offering some helpful suggestions. General premise being healthcare costs too much in this country. How are we going to cut expenses for that? And this is going to meander my way to the answer, but starting with a non-answer, I thought Emmanuel's suggestions were a good set of suggestions, right? He kind of talked through, okay, everybody's going to need to share in the trade-offs. Everybody today focuses on what they need to do more good stuff, but we actually need to focus on like, what would we be willing to give up in order to collectively spend less? And we all need to do that together and get out of this finger pointing scenario. That reminds me a little bit of that Spider-Man meme where everybody's pointing at each other and they're the same. And he suggested a couple things. He suggested no direct-to-consumer pharma advertising, PBMs moving to transparent systems, site neutral payments for hospitals, insurers capping out-of-pocket expenses, among other things. And I'm like, all of those seem pretty reasonable to me, right? No direct-to-consumer pharma advertising, great. Like, sign me up for that. PBMs being transparent, pass-through pricing, great. Site neutral payments, no real concerns on my part. I'd be all for those. It was funny to me to see the reaction in community social media elsewhere, where I saw a couple posts being like, if you add up Zeke's suggestions, this doesn't actually make a huge dent in healthcare costs, which to me is part of the issue with the construct of the question in the first place. Is it's hard to figure out how to do it. And whatever you suggest, you are taking something away from somebody else, and that is going to piss them off. It gets into the whole societal conversation about like how we collectively talk about these things. And I think that is just a really problematic and hard thing to do today. Like, I think you could think about some pretty drastic things to reduce healthcare costs. Like maybe we don't do surgeries on people over the age of 80 anymore, right? Or something wild like that. Obviously, that is going to come with a set of concerns that people have when you know somebody over the age of 80 who needs a surgery. Not going to hold water in any political setting in this country. So my thought in the newsletter was actually, what if we reframe the question to something that we have talked a lot about, which is, what if it's okay that we spend 18% of GDP on healthcare? And actually not just okay, but a good thing. We have the best, highest end healthcare in this country for folks who can get access and afford it. And what if, rather than trying to get that 18% down to 12%, we try to orient around higher value care in that 18% and potentially even spend more, introduce some new things that introduce access to new high quality care options. And perhaps that is getting away from this GDP reduction concept. Did I lose you, Martin?
I'm back.
Are you back? I was confused what was going on for a second. Getting away from the idea that we need to reduce GDP from 12% or 18% to 12% is actually the goal. And so I don't know. It's a bit of a non-answer. I don't know that I have any suggestions better than Zeke's on direct consumer pharma, PBM, site neutral payments, things like that. How about you?
Well, you caused a bit of a stir in the community after this article was published when you said, I like that hospitals are nice places and have artwork. And I think that that's a nice reframe of the problem. It's like, we are a rich country. There's a lot of different, better ways we could probably spend the money that we're spending today. But it is a luxury to be able to have a nice hospital. I spent a week at the hospital when my son was born, and it was a nice hospital. It was a Johns Hopkins property. And I'm happy that it wasn't, sort of barren and industrial. It was a nice place to spend a week. So
yeah, for sure. If you've spent a month in a hospital, like, yes, anyways.
Well, we are just a little bit past the top of the hour. So, kicking us off for the Grand Roundup, let's start with a quick rundown from the news of the week. Kevin, what are people worried about right now?
So one of the topics that we've discussed in the community is Epic's market power as it relates to AI and the impact that has on AI adoption. Excited to get into that later with you.
And we are also enjoying the New York Times discovering that there's a problem with the IDR process, which we'll be talking about a bit later.
I feel like we've helped raise awareness of that one potentially. I hope we could claim some credit for
Yes.
that. Another topic that we'll be talking about, also in the sphere of AI policy, is Doctronic Utah Medical Board, the escalating tensions that appear to be going on there, and how we move forward from that.
But first, it was a busy first week of earnings calls in the healthcare universe. And so we're going to start with that. Kevin, you included this graph or this chart in your newsletter. To kick us off at a high level thematically, can you talk about why you're trying to hire a meteorologist?
There was a big snowstorm in this country, if you hadn't heard, in January. And that snowstorm is the biggest driver of payer outperformance and provider underperformance, as far as I can tell from Q1 earnings calls. It was a fascinating set of results in that regard. You know, the payers, and referencing specifically to United, Elevance, and Molina, which all reported last week, all had similar talk tracks, slightly different version of it. Trend coming in slightly better than expected, although hedging a bit on how that will persist. Also, things getting better operationally. Each has kind of different flavors of that story. We'll get into later. But you know, that's kind of the two drivers on the payer side of the world, and then on HCA's side of the world, representing the provider landscape, they came out and they said, listen, January was tough because of that snowstorm. And it was interesting. They mentioned that respiratory, so flu season, it was trending well going into the year. And then all of a sudden it fell off a cliff in January, which coincided with that snowstorm.
And
Um,
Kevin, to be clear, when you say trending well,
Trending well means more people were getting the flu, and that was resulting in respiratory related ED visits and admissions, as I conceptualize it. I don't actually know that they shared the volumes uh, prior to this, but the miss that they cited in earnings, Martin, was respiratory volumes being down 42% and respiratory related ED visits being down 32%. So the combination of that snowstorm and respiratory volumes being down. Well, let me ask you this. In terms of impacts for the quarter between ACA, the state supplemental programs, which was a positive, not a negative, ACA was negative, and snowstorms, which was also negative, which do you think had the biggest impact on HCA earnings in the quarter?
I mean, I was shocked when you laid it out like this in our notes, but it was the snowstorms and the respiratory. It was something that no one
Yeah.
could have predicted.
Snowstorms, $180 million loss, snowstorms and respiratory. ACA impact, $150 million. And the state supplemental benefit programs were 120 million to the positive. It's wild to me. We spend so much time talking, thinking about what's the impact of ACA changes, what's the impact of these supplemental payments changing, and all here comes along a big snowstorm that shuts things down in the country for a week, and that's actually the biggest driver of financial results for HCA in the quarter beyond those two. Isn't that crazy?
So crazy. I also, so on the supplemental benefits note, one of the things that if you have been listening into hospital earnings calls is sort of fascinating to hear is everyone's getting nervous about Florida. So Florida submitted a state directed payment application a while ago. It's been sitting at CMS for a long time. It's a pretty big state directed payment program. And the hospitals are all sort of cautiously optimistic about it, but people are getting antsy. The big deadline here is because of the one big beautiful bill. You need to get it grandfathered in. It needs to go live relatively soon. Otherwise, it's not allowed. And so I thought it was interesting to hear their commentary on that. And then on the ACA front, they had sized the potential impact of the ACA expiration of the enhanced premium tax credits to between, I think, 600 to 800 million dollars, and it came in at 150 million for the first quarter. So that's better than expected. That kind of rhymes with what we've been hearing, that the drop off in ACA is not quite as large as we've seen. But you noted something, you sort of picked up on a theme from what they were talking about on uncompensated care, and a post from the folks over at Cedar, which I'm going to pull up right now.
Yeah, they made the point that they are seeing more patient pay, even on folks who remained on the ACA, because they switched, metal tiers and benefits change. So basically, more of the payment responsibility is falling onto patients. There's two dynamics at play here that I think are going to be interesting to keep an eye on for health system financials in 2026. Um, One is just that this general rise in patient pay, which we're seeing Cedar and I would imagine other startups in the space. I would imagine we're going to see activity here in 2026 as a result of this kind of increasing shift to, hey, we need to go collect dollars from patients. How do we do that in a way that maximizes the likelihood of collection, but also feels good in doing so and allows us to have high MPS scores while saying, pay me my money, please. The other dynamic at play that I thought was interesting that Cedar highlighted in a LinkedIn post, and we should have them on to talk about this, is as Q1 plays out and folks don't make payments, hospitals are going to have to do this math on, and HCA was talking about that they did this in their number, and I would assume HCA is probably best in class at doing this. But you've got to figure out, okay, if somebody shows up in January with ACA coverage, you don't know yet if they are not going to pay their bill. And if they don't pay their bill in March, it then comes back to that pay. Like, they've got a complicated equation to solve. I don't even know how to fully walk through all of that in my head, but like, there are folks on financial teams in these systems that are going to need to figure that out, because you're going to potentially go from ACA payment to uninsured or something else. And it's going to be something to keep an eye on.
Yeah, they talked about sort of scrambling the financial counselors that are on staff at the HCA hospitals to start to try to get ahead of this, because there's this lag, right? Where you saw the patients in January, they have till March to pay. It's now April, but we're still just kind of starting to get those numbers. And we'll hear more about that as we start to talk about the payer earnings calls and what they were seeing in the ACA marketplace. I think where I would like to leave it with HCA is another sort of act of God that is impacting the business, which is Hurricane Helen in the Asheville market. So you're, as a former North Carolinian, is that the right?
North Carolinian?
Carolinian.
North Carolinian? You're making me think about this. I think it's North Carolinian.
What's going on in Asheville?
Yeah. So, I mean, the Asheville market has in general been a fascinating market to watch. I think it was the Georgetown GHIR or whatever the last three letters of that are, had a white paper a few years back about the payer provider negotiations in Asheville and how it's a particularly complicated healthcare market because of the market dominance of Mission, which is, I think, now HCA, and the changes that have happened in that market over time. It was particularly hard hit by the hurricane when that came through. HCA provided an update on the earnings call. If you remember, in years past, they've made the note that markets that are hit by hurricanes can actually be better performing markets for a system like HCA over the long term as they build back capabilities in the market. Asheville is not there yet. That's what they shared on the earnings call. The reason why they said that was because they're having a hard time recruiting staff there, and the demand's there. So they're seeing demand coming in volume into the system. They're having a tough time recruiting staff, which is leading to higher costs to bring people in, right? They're paying more to get folks there. I'm sure there's a temporary labor mix as part of that. And the combination of those two things has it on behind track on its profitability expectations. The last thing they noted on the market as well is that the payer mix is actually unfavorable in the market, which makes sense when you think about it. There's been a workforce disruption in that part of the state. So presumably, they didn't say that the numbers or anything like that, but presumably that means commercial mix is lower in the state. You've got more Medicaid uninsured population going into HCA facilities there. So I thought it was really interesting to hear that update and think about just the impact of I think that was a 2024 storm that we're still seeing in Q1 2026 and presumably will persist for a bit longer too. And then all the downstream ripple effects of that, right? We talk a lot about startup models in Western North Carolina and primary care and value-based payments and whatnot. And so to me, it's a really interesting healthcare market to look at and ponder what the implications are. Do you have any further takeaways from that one, Martin?
No, I'm just going to quickly run through Molina before we welcome our first guest. So, Molina reported earnings last week as well, and they beat expectations on earnings per share, a slight miss on revenue. The MCRs, which is what medical cost ratio, medical loss ratio, which is what we pay pretty close attention to here. Medicaid, mostly favorable, which lines up with what we'll hear from the other payers. And some of that, I think, has to do with HCA's underperformance. Medicare was in line with expectations, and Marketplace was 84%. And that was inclusive of 450 basis points of prior year risk adjustment. And so Molina's risk pool ended up being a lot healthier than expected. And they kind of owed a big payback there, and then some program integrity stuff. And so excluding those two items, it was closer to 80%, which if you're a ACA payer, you want 80%. That's the MLR that you're managing to. Rate adjustments for Medicaid, it sounds like, are coming in as expected. The states announce rate adjustments. They announce them in different cycles, depending on state budgets and stuff like that. So that's an area that we're listening closely to, is impressions on rate adjustments. And then M&A, they said wait for the investor day. So wait, we will.
It's coming up in 2 weeks, right? I think it's
Yes.
2 Fridays from now-ish.
Yes. So I am going to start to bring forward our first guest, Allison Oakes from Trilliant. And Kevin, will you tee us up a little bit on this?
Yeah, for sure. Allie, Chief Research Officer at Trilliant. Excited to have you here. Trilliant does many of my favorite reports on healthcare data in the space. Always love learning from what you guys put out there. Recently put out a report on the behavioral health market and what that's looking like, and thought it included a bunch of interesting insights. So wanted to start off with just giving your point of view on state of U.S. behavioral health market and some of the key takeaways that you were seeing in the report.
That's a big one. Well, hi, Kevin. Hi, Martin. Thanks very much for having me. I guess the saying might go long time reader, first time caller, but I appreciate you having me on today. We at Trilliant have the privilege of leveraging a really vast set of data to tackle all kinds of different trends shaping the health economy. And just a few weeks ago, we released a 80+ page report that was focused entirely on behavioral health. And that's leveraging all kinds of secondary data, but also a large national all-payer claims database, also data directly from the health plan price transparency files, and then our provider directory too. And in a lot of our work, we use the lens of supply, demand, and yield to try and understand what's going on within the healthcare space. And really the punchline from the behavioral health report, we're seeing more demand than ever, inadequate supply that doesn't seem to be catching up, and we're seeing confusing and variable costs that patients are up against. So unfortunately, it's not such a great picture from our point of view at this point in time.
On the demand side of the equation, can you break us down a little bit of what's going on with acuity, intensity, utilization that's driving that increased demand?
Yeah, absolutely. So I think demand within the behavioral health space is particularly interesting. It's the case everywhere clinically, but I think even more so within behavioral health, where there's always the question of, okay, is an increase in utilization reflective of increased need within the clinical area, or is it a matter of need that's always in there, but with more access, you could see an increase in utilization? And then there can always be a little bit of a piece of the pie too that could have to do with sort of overdiagnosis or overutilization too. So when trying to sort of decompose that increased utilization within the behavioral health space, I do think a lot of it has to do with that increased need. So we heard a lot about this during the COVID-19 pandemic. I think being 6 years out from it, there were theories that maybe we would see a reduction in utilization that might happen or a reduction in prevalence, but that just doesn't seem to be the case. When doing these sorts of data analyses, it can be so easy to really get down into the weeds and sort of like miss the big picture. And I have to remind myself, taking a step back, we see 23% of adults that report any mental illness, so basically a quarter of our population. And it's nearly a third in our 18 to 49-year-old working population. So just like wrapping your head around that number, I think is pretty staggering. And from a spending point of view, we do see that about 8% of personal healthcare spending or total healthcare spending is on mental health. But I think the more important number is actually what we spend on untreated mental health. That number is closer to $500 billion rather than $200 billion on actually treating it. And that untreated number sort of encompasses chronic physical illness, ED overuse, productivity loss, and premature death. So I think like primary care, it's one of those healthcare spaces where we probably need to be investing more dollars, actually.
Interesting. Allie, how do you do the math on, so if I'm understanding that right, $200 million of costs today, $500 million of potential costs that's not actually, we're not actually spending today. How do you do the math on like quantifying that $500 million number to know that that's what it's at?
Yeah, and it's 500 billion with a B
500 billion,
and 200 billion
yes.
with a D.
Yes,
Yeah. No, just such large numbers we're always dealing with within healthcare. Those particular calculations we are sourcing from secondary data. In terms of that direct medical spending, it would be care directly related to, treating disorders that kind of pop up within the F section of the ICD-10. So depression, schizophrenia, all that sort of stuff when people actually go to a healthcare visit or possibly the ED, something like that. When it comes to those untreated related costs of mental health, it's really importantly the way that mental health or behavioral health issues exacerbate physical health conditions. So I think that's another really important thing to remember related to all of this. Like, yes, the report is focused on behavioral health specifically, but we know there's this really important relationship between mental and physical health and the way that unmanaged mental or behavioral health issues exacerbate those physical health problems. So there's a lot of additional costs and utilization that goes on there when one of these conditions are unmanaged. And then also there's issues related to where people do receive care for these conditions too. So there is some amount of, if people can't access care, through an outpatient therapist, they might find themselves in the emergency department for some sort of flare up. And we know those visits are really expensive. So that sort of like misutilization of the healthcare system goes into that untreated care bucket too.
Over on the supply side, I'm curious to hear where the gaps are most acute. Where are we seeing like a real lack of providers that we need more of, and maybe on a sort of specialty or subspecialty basis there?
Yeah, so we certainly know that the behavioral health provider space is pretty heterogeneous in terms of provider types. So, thinking about primary care, for example, and many other specialties at this point too, you have your physicians, and then you maybe have like an allied health NP, PA workforce that's helping to supplement at this point in time. So we see that within behavioral health too, but there are additional providers in this space as well. So there's master's levels clinicians who actually make up the majority of the workforce. There's also clinical social workers who practice in this space. There's doctorate level psychologists. There's our MD, DO psychiatrists. And then we're seeing this more sort of specialized psychiatric nurse practitioner workforce start to emerge. I think something that's really interesting here in terms of the potential for sort of artificially constrained supply and that being a problem. From 2018 to 2024, we do see that the number of psychiatry residency positions has actually increased by 55%, which when we talk about the AMA residency match and all of that, there's always conversation about needing more slots. So within psychiatry, we actually see that the number of slots has increased somewhat significantly, but year over year, those slots are filled at 99% or so. So there's sort of demand from the practitioner point of view, if you will, to get into this space, but it seems like we just aren't creating enough positions. And I think one other interesting thing we see here, one, nationally, sort of our adequacy rate of mental health providers is only around 25%. So we're doing pretty dismally as it relates to that. But in terms of how the supply market is trying to adjust, one thing that we did look at using our own data was for folks who are receiving a medication related to mental or behavioral health, we took a look at who the prescribing provider was. And over this period of time, we see that the allied health profession is actually prescribing the largest proportion of these medications. So by 2024, we see that those allied health providers, since 2018, they were prescribing around 20% of those medications. As of 2024, they're prescribing around 34%. And together, allied health and primary care providers are prescribing 2/3 of all of those medications. So we can see how sort of a non-specialized mental behavioral health workforce is having to flex into helping and meeting the need of this growing patient population.
Allie, it's time for AI to enter the chat here. A big topic in the community is AI care delivery. What's happening with that? Certainly, it seems like there's activity within the AI mental health chatbot, et cetera, front. I'd be curious, are you seeing any indications, data around is AI helping increase productivity in the mental health market? And projecting out the next couple of years, like, is there a point at which you think we see more indications of this, learn more about how AI is impacting the space and when that shows up in the data?
That's a great question. I mean, I think in terms of how AI relates to mental and behavioral health, we have to take a step back and think about the continuum of, okay, what might we want or ask AI to do within this space? In general, right, we think about AI as being a really good use case for repetitive sort of administrative tasks. So where we can create efficiency for our providers as it relates to helping to reduce their administrative burden, great, that's a really good application. When it comes to more clinical use cases, I think that's where there's still a big question mark. I think there's been some legal activity in this space recently that raises a lot of questions about our sort of willingness and interest to do this and the gray areas that it introduces. Certainly something that came out of the COVID-19 pandemic is this proliferation of sort of direct-to-consumer providers within the behavioral health space. The extent to which any of those providers are using AI, I'm honestly not an expert on, but as it relates to the direct-to-consumer providers and the extent to which they might start working AI into their workflow, I do think there's a question of sort of fragmentation that it could introduce. So again, with that sort of mental, behavioral, physical health connection in these new providers that are popping up, how do we make sure we're still being able to provide sort of high quality, holistic care to this patient population? And then I think there's a cost question there too. I think there's an assumption that AI supplemented care will inherently be less expensive. But I think if there's anything we know to be true with healthcare prices, it's that they don't usually do what we would expect a regular market to do. So I don't think there should be an assumption that AI will bring down costs to patients or costs to the system. And that's actually something we already see with the direct-to-consumer providers. So that's something we unpack in the report. We sort of take a use case, a patient who wants to do weekly therapy, if they pay out of pocket through one of these direct-to-consumer providers versus finding a traditional provider who's in network for them and they use their insurance. The ease of doing that is a whole separate question. But we see the traditional approach is actually on average less expensive for people. So I think that's a combination of things without totally trying to get into a crystal ball of what's going to happen related to AI, but some things to pay attention to.
I think we have time for one more question. And I was hoping to talk about another sort of new and novel technology in behavioral health, though this is more on the interventional psychiatry front. So we've seen a lot of increased venture capital activity and wider adoption of TMS and Spravato and some of these things. I'm curious if you're from, in the report section, like what are we seeing here from that perspective, going beyond the sort of traditional first line treatments?
Yeah, so we just sort of give a little bit of a lay of the land of some of these emerging technologies. So like you mentioned, TMS, things like psilocybin, MDMA. There's definitely sort of this emerging market, I think, focused on treatment resistant issues or sort of alternative or novel ways to be treating some of these conditions. And I think it's just within the last couple of weeks, we did see that the Trump administration put out some sort of announcement about thinking about funding more research in that space or coming up with some more flexibilities as it relates to trying to approve treatment within that space. So again, to the extent that behavioral health is something that's impacting a quarter of our population, I do think just that there's a discussion around sort of novel treatments and new things that we could be trying and that we're seeing innovation as a very positive signal. As with anything, though, it's just a matter of very carefully implementing or, testing out these new technologies. There's also sort of a software as a treatment element here too to consider, and what the pathway for approval for those sorts of treatment looks like too. So I do think there is some exciting sort of new things coming to the market potentially.
Allie, this was a great overview. If folks haven't read the report yet, where can they find it?
If they go to our website, trillianthealth.com, and on our insights page, they'll be able to find the behavioral health report as well as our annual Trends Shaping the Health Economy report. And then we also put out a weekly analysis as well that covers sort of any topic under the sun.
Very much worth a read. Allie, thanks so much for your time today, and I hope you have a great rest of your day.
Thanks for joining us, Allie.
Yep. Absolutely. Thanks, Kevin. Bye. Thanks, Martin.
I'm going to be thinking about that D2C cost increase point for a while.
Yeah.
It rings so true to me. And like, it is completely non-intuitive when you just think about like, oh yeah, if we're gonna have more D2C solutions, it's going to be great for everybody. And, classic iron triangle.
It is
open up access and
yes. It is also an interesting accounting exercise, right? So if you think about the national health expenditures and we think about where those costs end up, something that's D2C is coming, and it's being spent out of the personal or consumer health expenditure bucket, not the insurance expenditure bucket. And there's some people who say, well, that's kind of a good thing. Like, that's market forces at work. Like, insurance isn't covering this thing. People are spending their own money. But if your metric is the national health expenditures, yeah, it's going to make those numbers go up, especially in ways that are people, drive people crazy. Like, people spending their own money on healthcare is something that people really don't like.
Are you saying that this should have been my suggestion for Zeke earlier in the conversation about how to reduce national health expenditures? Just shift it to the patients outside of the budget.
That's what we've been doing for the last 10 years. And let me tell you, it is bad politics. Like, the Brookings put out a paper a couple of weeks ago that made everyone really angry, which said, like, actually, we modestly did bend the cost curve. And the way we did it is by requiring more out-of-pocket spending from patients. And everyone went nuts. But yeah, it's like that's a way to manage utilization, is to take that spending and say, okay, would you be willing to spend your own hard-earned dollars?
Mm-hmm.
People really like talking about Singapore. I am one of those people. One of the things that they do is they have a sort of national insurance scheme, which is conceptually similar to Medicare Part A. If If it happens in a hospital, it's covered by the national health insurance scheme. Anything outside of and that's for everyone. Everything outside of that, though, you have to use a MediSave account, similar to an FSA or an HSA account. And people like this because they're like, well, it helps price discovery work. I also think that if you tried to do that in the US, like people would be so angry.
No argument for me. Should we go back to earnings for a minute?
Yeah, let's go back to earnings. Let's talk about Elevance quick.
Yep.
MLR, medical costs modestly better than they had assumed, favorable claims, and some impact from their own utilization management stuff. So you'll be hearing a theme when we talk about the payers that trend was better than expected. And you line that up with HCA's experience, and most of the payers were very careful to not say like, hey, don't call it a comeback quite yet. Elevance, though, raised guidance for the year, and so hopefully they are on top of that, and this wasn't just a respiratory-driven improvement.
Yeah, Elevance and United both raised guidance. Elevance, it was interesting. A couple points that I heard on the call that I found interesting. One, it sounds like they're integrating CareBridge, which was their big acquisition in the VBC space and inside of Carelon and their home health capabilities into a single risk model, which they seem to be finding success with. I'd be curious to hear more on that over time. It makes sense to me why they're doing that, but thought that was interesting. MA is tracking to a 2% margin, which I think anybody in 2026, most organizations in 2026 would be very happy with 2% margin in MA. Take that and run. And they are apparently working through their issues over flash drives with CMS in a way that does not sound like it will impact the potential enrollment freeze will not impact them. But they booked almost $1 billion in accrual for kind of the settlement of that.
Yeah, they talked about it very briefly, and you're like, oh, that's like a pretty large accrual for. Yes. But
I know that's a big number, almost $1 billion.
It's a big number.
And lastly, the second blue bid thing I thought was interesting. They talked about that, which we'll keep on coming back to. Should we bring on Neil?
Yes, we're bring in Neil. Hey, Neil.
Hey guys, how are you doing?
Good. How are you today?
Oh, I'm good. Sorry, I'm good. I'm middle of moving, and so I want to make sure that I got internet's good. It's like a chaotic time out here. I'm trying to hide all the boxes.
Yeah. No, you look great. I think a good place to start would be just like a quick update on the pair team approach today for viewers and listeners who aren't as familiar.
Yeah, of course. One, thank you guys for having us on. So for folks that don't know, Pair Team is an AI-powered care management group, and we focus on individuals whose health first starts with housing, food, transportation, and other kind of basic life needs. And so we provide both system navigation across our healthcare and public assistance programs, but we are also a full stack medical group. So we are a full stack virtual medical group with NPs, RNs, behavioral health specialists, so we can kind of manage manage a patient from any sort of health or life need they have. And it's been a ton of fun. I think things like access make this pretty exciting. And I know we were going to talk about that a little bit.
Neil, give us so access. You also wrote a paper recently on AI and Medi-Cal and the opportunity there. Give us a sense of just scope and scale of Pair Team business today. When you say medical group, is it virtual medical group? Are you in person? What markets are you in? How do you think about the world?
Yeah. So we started this organization and focused on a very high needs patient population. So focused on individuals experiencing homelessness, severe mental illness, substance use, polychronic, folks that are frequenting the emergency room. And we focused in high needs Medicaid, particularly in a program that came out in California called Enhanced Care Management, which was a super aligned. And one of the problems here that you see is the handoff problem where someone, this fellow Cody Kinsley, North Carolina State Health Department, State Medicaid director, used this term pamphlet and pray, which is someone walks into the emergency room and you go, well, hey, here's a pamphlet to get to the resources that you need. Do they get there? No one knows, right? And then you have platforms like Find Help and United, which help like create all the connectivity. But even then, it's still hard to like actually close the loop from a services perspective. And so where Pair Team has been is focused on that high needs population in a very full stack approach. So we have this virtual medical group, but we also build out a direct network of contracted social care providers and medical providers. So we'll partner with libraries, with food pantries, with sobering centers, with YMCAs, all sorts of different community-based organizations that are integrated into our model so that you can provide and get, you reduce that handoff risk. You can actually get someone to their care. Last year, we put out a paper. This was showing our outcomes, 52% ED reduction, 26% inpatient reduction. It showed the model really working if you have community health workers, a virtual medical group, and this last mile care delivery network. About 9 months ago, and Kevin, I'll get to the paper on AI, but just to give folks the story. About 9 months ago, our mission has always been whole person care for everyone, not just whole person care, for a high needs population. And to do that, you really have to lower cost to serve. I think everyone knows what Medicaid rates look like. It is, for someone to go through the Medicaid system is truly heroic. It is incredibly fragmented. You have all these life needs, kind of trying to work up Maslow's hierarchy of needs for yourself. And you got to do it alone. How do we bring our personal care management touch to everyone? We've been focusing on AI and what that can do. And about 9 months ago, we had this, what I'd call like a watershed moment for us, where we had built a first version of Flora, who is our AI care advocate. Kind of trained her with all of our protocols that we had. And she had a voice call with an individual. This was a senior living out of her car, PTSD, congestive heart failure. And it was over an hour-long phone conversation. It was way deeper, way more rich than we could have expected. And like both you go, wow, the tech is here. It's also kind of heartbreaking at the same time in that moment of just realizing kind of like the social isolation that happened, that's so pervasive. And so as soon as we saw that moment, we said, okay, we're here. This is our way to get whole person care to everyone. And so what we've been building is Flora, who is, like I mentioned, our AI advocate who can help engage with someone over voice and text and not just be that 24/7 care manager, but also be a companion to them, but still backed with our full care model, full backed by our virtual medical group, our last mile care delivery network. It's not just ChatGPT about health, right? And so as part of that, we entered into, we've been talking to CMS and CMI about the Access program, and we are now officially an Access participant, bringing that whole person care model to the safety net. We believe that care management requires not just health navigation, but also public assistance navigation as well. We've been building out this model forever, and Flora can now drive it and be the core kind of interface for it to bring it to a much broader patient population. And as part of this, we've been really investing in obviously safety, effectiveness of Flora. It is now it's not typical for us to have 45-minute, 60-minute long conversations with seniors who Flora is actively caring for with support of our care team. And alongside that, we've also just been very deep on infrastructure for the safety net. I think when you see things like, when EMRs came out, you saw this technology typically kind of gloss over the safety net. You still have FQHCs that are using very outdated tools relative to commercial counterparts. And we want to make sure that doesn't happen here. So we're thinking about things like if you are a state health department, if you are in the federal seat building out Medicaid IT infrastructure, how do you make it AI native? Right? How do you, I can go a little bit into that, but we put out papers on this is what our spec would look like and do everything as open source as possible, but incorporates things like, let's break down the data silos with, model context protocol interfaces, that are kind of more agent ready, and consent systems so that people have control over their data and kind of own it. That's a very important part to all this. But that's been Pear Team's journey in AI. Is we started this whole person care model for high needs individuals to bring it to had our watershed moment, and now bringing it to everyone in the safety net with Flora, our AI care advocate.
I'd be curious to hear how you process. It feels like there's kind of two camps emerging. One on the side of AI saying, "Hey, this is too big of a challenge to not use AI." And so we had Andy from Town Hall Ventures and Toyin from City Block talking about the need to sort of really engage with AI to support folks who are enrolled in Medicaid. And then the other side, you were starting to see some pushback from folks like the Medical Board of Utah on the Doctronic pilot, basically saying this is moving too quickly, the incentives are bad, we shouldn't be treating patients like guinea pigs, some other corners. Curious how you process that debate and how you're thinking about those questions.
Yeah. Also, I realized, Kevin, I didn't answer. We are coming up on 1,000-person medical group right now.
Wow.
So we've gotten to a pretty decent amount of scale.
That.
Yeah, from a data.
That's awesome.
I was like, I feel like I buried the lead there. We're a big group. We take care of a lot of folks. We're putting out meaningful papers. Like, this is why I feel like we have kind of the raw inputs to do this safely and effectively. Which, Martin, comes to your questions. It's more about the safe and effective rollout of this technology, because when you actually look at the need, we were in West Virginia, for example, 92% of the population is on government healthcare. But you have folks in these very rural areas that just do not have access. They actually closed down a series of OBGYN clinics, and expecting moms have anywhere from 3 to 4 hour drive to get to a hospital to actually give birth. Right? These are just like fundamentally challenging problems with access. So I think AI has to play a role, and it's getting exponentially smarter. Right? You see what the frontier labs are doing. I don't think you just jump into prescribing, right? So how I process this, and this is actually Pear Team's approach, is we're first starting with navigation and orchestration. So Flora, for example, can say, okay, I'm interacting with you over voice or text. If I need to invoke an NP, I can schedule that resource. If I need to coordinate with the PCP, I can schedule that resource. If I need to coordinate with a housing organization, I can coordinate that resource, right? And over time, what you're going to be able to see, and we're already seeing it now, what are the things that Flora and these frontier models are better at? And what are they technologically ready to do? Both, I guess, 3 components, which is also regulatory compliance, right? So that's the other rate limiting factor. But by starting with orchestration, you can see like, well, in this case, it might actually be better for me to use Flora to prescribe in these certain XYZ cases, and you can A/B test it, and you can start to roll it out in a much more data-driven way. And you're looking at evals on safety and also quality, like the experience that an individual gets. So we are optimistic. Like, over time, I do think a lot of virtual care is just going to get taken over by agentic tools and agentic companionship. I think the question is going to be, and it's going to fill about this very big need of access. But if you start with orchestration and navigation, you can then figure out safely where to push AI into to deliver the highest quality care.
Neil, on access model, not access to care, but CMMI's new access model that they're rolling out. Big headline has been there's been a lot of consternation in digital health community over rates, how folks have been thinking about rates. And we saw when the model was announced, a lot of folks expressed their interest in participating and then fall out when rates actually came out and didn't apply to the program. I'd be curious to hear your perspective on how you're thinking about the opportunity in the program, and then how you think about building the P&L within the construct of that program. CMI has been pretty clear in saying, like, you can't think about it from the incumbent mindset. You got to build from the ground up. How are you processing all of that, interpreting it for your organization as you're leaning in here?
Yeah. So I'll start with we were expecting these rates. We were not expecting anything higher. It's a feature, not a bug, so to speak, right? To drive down, and actually get to deflationary outcomes, right? So that was all expected. What's really interesting is when I talked to CMI and Abe about how these rates were formed. I was like, oh, are you forming them? Like, give us the methodology, right? And instead of looking at it from a value delivered perspective, the rates are actually composed more bottoms up from a cost to deliver perspective, right? Which is very different, than how you develop a value-based contract or anything. It's like, well, we believe it's going to be cost X, and let's do a cost plus model on top of it. How we are thinking about this internally is we're looking at, because we've have just millions of data points on the actual workflows and orchestration of care. And we're saying, well, over the course of the next, is it at what percentage of automation can you do now? What is going to come over the next 3 to 6 months? What's going to come over the next year? And you actually build this kind of, waterfall roadmap for task automation there. Things like scheduling with PCPs, right? That no longer has to be something that a care manager has to do. She can, he or she can focus on higher leverage tasks. That then leads to our COGS there. And we have this very kind of confident roadmap in front of us on making all this work with an agentic service. I think maybe to make it a little bit more interesting for the listeners, two of the big key components are going to be CAC, and they're going to be like, how do you actually acquire folks at all this? And then I've had some consternation around device cost and blood pressure device cost there. And on the CAC side, I think there's this is really incentivizing partnerships. It's really incentivizing access providers to go out, partner with ACOs, partner with PCPs, right? So that you're not like D2C online media spend is not going to work. You're not going to be able to pay for Google ads and Facebook ads to make this program work. You have to go through either build a great brand or get channel partners in place. And then on, so that's one side of the equation. And then the other is things like device costs. They're a hit now, but have talked to Jacob and other folks in the CMI team. There's these hardware costs are going down. I think there's a thought that they're going to build a tool directory, so preferred vendors for these devices, right? Which will give having the U.S. healthcare system be a buyer gives you great discounts. And he can pass down those discounts to access providers. So while it's a little bit of a pain right now, I think we'll get over it with the support of CMI.
Neil, this has been great. Where can folks get in touch if they would like to learn more, want to chat, are a state Medicaid director and want to team up?
Yeah. If you are any of the above, if you're state Medicaid directors, health plans, we are taking this program and we are actually working to bring it into managed care. So what does AI care management look like? And our flavor of it, right, is whole person. It's the social and the medical side. Please reach out to myself, neil@pairteam.com. And if you're a builder in the space, I think we have a lot of the raw materials to build an AI care manager in a way that is just higher quality than anyone else can right now, and we're pushing on it. So if that excites you, please reach out. We'd love to talk.
Neil, thanks so much for your time today. We'll catch up
Appreciate
soon.
the update. Good seeing you, Neil.
Right.
Good luck
Thanks,
on the
both.
move.
All right, see you guys. Bye. Thank you.
That was great. 1,000-person medical group is I chatted with them it feels like they're just growing like crazy.
Yeah, that's good for them. That's an awesome group. It's one of the things we started chatting about last week that his commentary made me think of was this idea that in this AI centric world, it's actually going to get harder to reach the hard to reach populations in healthcare. Like, I already don't answer my phone today because of all of the spam calls I'm getting. And as fraud spam risk rises through digital connection points, like it's going to be tough to figure out how do you connect with these different populations. And I think there's a huge opportunity for groups thinking like Pear Team, thinking about that question in an interesting way.
Absolutely. Should we wrap up Elevance and move on to United? So we talked a little bit about the USB drive saga, but what's the second blue bid? What was the commentary on the second blue bid?
So it was essentially, things are going gangbusters in the commercial market. We're doing really well, got a lot of momentum there. Elevance seems excited there. But then they were like, it's not actually in the second blue bid anymore. They noted on a previous earnings call that that second blue bid was going great for them. I think they won 9 out of 11 second blue bids. Of course, the second blue bid is the dynamic that came out of the antitrust suit with Blues plans, where, let me try to make sure I get this right. Employers that have a single state blue plan can put up that their business for a bid from a blue that is not in the state as a second blue bid to see if they'd prefer that. Not surprisingly, Elevance is winning a lot of those cases, and that's what they noted on their earnings call. So it was interesting to hear them kind of downplay the opportunity in that moving forward, which I can't help but like. If you're in the group of Blues plans, like they all know each other, that comment could not have gone over well among the Blues plans, or I would imagine antitrust regulators, because that is like the opposite of, hey, we're putting it, we've got this to help employers with their Blues costs, and the result is all Blues just get aggregated up. Like that's no bueno.
To say the least. I mean, and we are seeing a lot of consolidation in this space because Elevance is, for better or for worse, a consolidated blue. And so,
and state health plans have a bunch of it. We've thought like it's, anyways, it's an issue.
The last thing I'll say about Elevance is they got an analyst question saying, hey, can you talk about some of the proof points today you're seeing on the AI stuff? Any progress on that front? Quantify those efficiency gains. And the quantification they shared was just sizing their investments. And I just want to say I am so excited for someone to share actual productivity statistics at some point instead of just saying we spent all of this money and we think that there's going to be a return on investment.
I'm excited for that moment as well. We might be waiting for some time, but nonetheless, we'll keep our eye out for it. Flipping over to United, last big earnings call. United was up 10% on the week, like some of the other payers here. In general, I thought business performing on all fronts well. United raised expectations for the year, but nothing too meaty in terms of strategic updates on the earnings call. Medicaid continues to work through rate pressures. Medicare seeing some favorability on trend. Optum Health continues its turnaround. There were some interesting data points there, I thought, around the fee-for-service business in Optum Health and how they have, I think, increased fee-for-service scheduling hours by something like 12%. That was interesting to hear and I think about. Lastly, Optum Insight cited as a lot of potential. Optum Real cited as the example there. Again, to the Elevance AI theme, like you can imagine the narrative. We'll see when it starts to materialize for them. Lastly, it was interesting to see United made a small acquisition. I don't actually know the full dollar amount of it, but seemed small in the broader strategic narrative is what I mean by that, of a company called Allegis Technologies in your favorite part of the world, Martin, FSA, HSA markets. What do you think of that?
Yeah, no, I mean, so you go to the Allegis website and it looks like pretty sort of standard FSA, HSA, management for employers. And so I think in some ways this represents a bet on that being a larger part of the story and of benefit design going forward. It checks out. There's also some mentions for ICRA. I think that, as you think about where spending is going to happen, you have insurance dollars and you have personal dollars, but then you have this sort of weird center model with the HSA and FSA, and that feels, I think, in some ways more palatable to people than just the personal dollars. Should we talk about the independent dispute resolution process?
I would love to. New York Times had a good article on it this week. This is the somewhat outlandish picture from the headline. It covered, I think the doctor's name is Dr. Norman Rowe. He has had a lawsuit filed against him with some kind of egregious cases and outcomes in the IDR process, including a $440,000 breast reduction. As an example, despite the fact that he's advertising that procedure on his website, I think for $15,000 to $25,000 ish, according to the headline of the article. Martin, to me, there is no better example of, we talk a lot about fraud, waste, and abuse in healthcare and how we want to drive down waste. And the IDR process seems like the best example of this to me that we have in healthcare right now, that is happening in front of our eyes. Like, this is happening as we speak. The New York Times article highlights how we have essentially conjured up a brand new cottage industry of these arbitrators who are making bank off these cases, so much so that they've now got their own trade group that is now lobbying for it. And you can see how these things just like ossify in American society, because once you have a trade group, like, lobbying dollars are going to DC. This thing ain't going away, right?
Yeah. I think that it is common for people to get really angry about, or feel very cynical about the fact that, look, there's just like no way we can improve healthcare. And even when we try, our policymakers end up with solutions like the IDR process, which just end up raising prices. I think it's like worth taking a step back and saying, number one, the IDR process and the No Surprises Act was wildly successful at one of its stated goals, which was to stop patients from getting surprise bills. That is just like, that was a bad thing that happened, and they solved that problem. How you solve that problem is actually very tricky. So the insurance companies, when the No Surprises Act was being debated, said, we think the government should just set a rate. And that if we can't come to an agreement, it should default to that, sort of rate setting. And, methodologically, there's lots of different ways to come to that rate, but that was their idea. And obviously that's favorable to an insurance company. That's why they were advocating for it, is because that rate would probably be less than what they were paying, or approximately what they were paying. And providers didn't like this. And as often happens in a democracy, the legislators in Washington split the difference, or in the truest sense of the phrase, pulled a King Solomon and tried to split the baby. So they did a little bit of like, hey, here's this rate that you can use, but also we're going to do baseball style arbitration.
Mm-hmm.
And the baseball arbitration kind of favored the provider groups. So here we are, I think it was implemented in 2022, and the rate setting never really materialized. The Texas Medical Association sued and got that deprioritized. The baseball arbitration sort of has come to favor provider groups. And we're left with, people paying $440,000, or insurance companies paying $440,000 for a procedure that costs $15,000 to $25,000. It's hard. It's a hard problem to solve. And I think we should, respect that problem rather than just like roll our eyes and be very cynical about our government's inability to do things. Like, they solved the problem.
Mm-hmm. For sure.
Kinda.
Yeah. It's got unintended consequences, right?
Yeah.
I thought it was interesting to see Senator Cassidy, who I think is one of the authors of the No Surprises Act. He was quoted in the New York Times as saying of the outcomes for providers, quote, if they're winning, it's because the insurance companies are not coming back with a reasonable thing, which I think expresses, to your point, the provider sentiment in all of this of, yeah, we're winning these cases because the insurers are not paying enough, generally speaking. And to your point, that is the underlying debate more broadly. It's just a question of how we do that. And when programs like this come into place, there's a natural byproduct of it, of things happen. There's unintended consequences, right? You get providers who are charging that $400,000. Crazy
Should
times.
we talk about Doctronic a little bit before we welcome our next guest?
Let's do it.
So
This is a
I was just going to say, you made a comment in the newsletter this weekend about how you shouldn't ever pick a fight with a state medical board.
I think it's a losing proposition. This is the group who feels they are entrusted to protect the health of folks in the state and have providers supporting it as such. And they certainly did not like the way Doctronic and the Utah Department of Commerce rammed through this new AI policy, rammed through, I think, from their perspective. They felt like they were not brought up to speed on how the Doctronic pilot for prescription refills came to be. They are not pleased about that. And as you see in their letter to the right here, it is their strong recommendation that the program be suspended pending further discussions with the state medical board. I get that. If you're the state medical board, this is going to be your reaction. You are not going to be happy about this. I think there are two potential reactions to the state medical board's reaction. One, valid concerns that they have. They are trying to protect the safety of patients in their communities. And this is an unproven technology that puts that at risk. On the other side of the equation, there is they are just protecting their turf. And as Doctronic penned in a blog this week, the status quo is the biggest risk here of all. Doctronic's blog post, I thought, was actually a really well done piece. It wasn't directly critiquing the state of Utah by any means, but conceptually, I think it's a critique of the response and why we should have more tools like this, suggesting that this is a human capital problem and that actually these tools are very safe. And in programs like in states like Utah, they're not actually doing AI prescribing yet. Like, we talk about this as AI prescribing, but underneath it in fine print, they actually have humans reviewing all of this until they can prove and demonstrate that it works. And it's like, that seems pretty reasonable to me here, Martin. In so many ways, I think that if you were stepping back from the politics of how this decision were made, what Doctronic has indicated is happening here, and I don't think we've heard from the Department of Commerce explicitly on how these decisions were made and whatnot. We've seen a lot of the letters going to them. This is what you would want. Like, I would appreciate more of this from state, federal governments and taking these behaviors. And I think this is going to be the thing to watch play out. It has always been our concern with AI and care delivery of how state medical boards and other groups react. And you can see it here. I think Doctronic's up to some really reasonable stuff as I look at all of this.
It is interesting to think about, Doctronic really hit it's AI prescribing hard, and then it's like asterisk subtitle, not quite AI prescribing, and also just for refills, and then the sort of inevitable backlash. Yeah. I am going to bring forward our next guest. Amanda, welcome to the show. Hey. How are you?
I'm doing well. How are you?
Doing great. We were just talking a little bit about AI in Utah, but we're excited to be hearing from you about some sort of different technological applications. So you're the CEO and co-founder of Bold. Can you give us a quick overview of what Bold's technology does? And then we'll talk about access and some of the other.
Yeah, so Bold is an AI platform focused on healthy aging, and there's two components. We have an AI clinic really dedicated to serving Medicare members, as well as AI-powered lifestyle programming. So that's exercise, education, behavior change tools and support, and some community services to actually help someone between those clinic visits actually adhere and sort of take control and build those healthy habits that add up to changing how someone's aging.
One of the things I found, sorry, you go,
Martin. No,
I was going to say, one of the things I found interesting was the focus on falls prevention. So my mom was a falls prevention coordinator for a while, and it is a very challenging behavior change project, right? Behavior change is one of those things that is the silver bullet in healthcare. If you can get someone to change the behavior, you can do a lot. I'm curious what your sort of focus is when it comes to, or approaches when it comes to sort of changing behaviors.
Yeah. So you're right that we started with a focus on falls, and for us, our big mission has always been close the gap between health span and lifespan. So where there's been a lot of longevity focus on adding years, we were focused on how do you make most of those years as healthy as possible. And falls are often that moment where you see a split between how healthy someone is and how a steeper decline once they've had a fall. I think falls are so ubiquitous that everybody actually has somewhat of a latent awareness and fear of falling, or fear of falling is quite common and can actually feed into fall risk. And so our initial proposition, and as we've expanded the other types of things like musculoskeletal pain management or chronic condition support, weight management, all goes back to what are some of those big barriers or things that start to become really top of mind as you're aging. And I think fundamentally behavior change requires someone to want to make the change. You can't sort of like force a change. And so by finding ways to speak and connect to a topic like falls, but not make it, we're going to bubble wrap you and try and keep you from falling by sort of controlling you. And instead saying, hey, you actually have a lot of agency. If we can help you with tools, build strength, balance, mobility, then you can keep doing the stuff you want. You can go out, run errands, go to the gym, garden without feeling unsteady or off balance. And I think that sort of approach to tapping into a problem in aging that's maybe not fun to talk about, or maybe has been talked about in a more tense or sort of like confrontational way, applies to many other topics in aging. And so it's really about building for that Medicare member who I think, before Bold, not many digital health companies said we're going to start with Medicare. It's often we'll build for a different population and try and copy and paste. And I don't think that works as well. So really knowing our Medicare members and being able to build and support them and grow and learn from them, I think has helped us be the most successful at unlocking those longer term engagement and behavior change wins.
Amanda, I'm curious, when I first started hearing about Bold going back a few years, I had in my mind, okay, fitness benefit. And when I think fitness benefit, Medicare, I think silver sneakers. And I'm like, okay, like kind of alternative-y to that. And then now I hear about it and I'm like, okay, kind of more virtual MSK type model and entering into that space. Can you help me with like, what's the right conceptual model there at a very high level, and how help me think about that?
Yeah, I'd almost say it's really actually around that bigger umbrella of lifestyle change. What are the changes that happen and what are the actions that need to happen between your clinical touch points? We started with exercise and movement as medicine. Movement as medicine encompasses both fitness benefit and more intensive, programmatic clinical musculoskeletal interventions. But our thesis was movement as medicine is it's like the number one thing. If you could ask any primary care physician, exercise should be part of someone's care plan, and it's the least adhered to part of most people's care plans. And instead, there's a focus on med adherence or nutrition is also very important. But the feedback loop of I used to be active, I'm less active. If we can restore activity, it's not just falls, it's not just fitness benefit loyalty to an MA plan. It's actually a transformation because exercise positively impacts every organ system, and there's very little downside to increasing activity. So Kevin, it's a great question, but I would say it fits within, hey, how do you actually drive lifestyle changes and deliver lifestyle programming with an eye towards aging? It's not sort of a near-term shift. It's not around optimizing for some long-term ROI. Our ROI and our sort of transformation can happen in a matter of months, right? Single-digit number of months. And that's really different. And it's pretty cool from a prevention lens. As far as, where the appetite has been in the market for that has historically been within MA. And I think that's why the silver sneakers comparison is worthwhile, because it's been there have been dollars in benefits to attract members to sign up for MA plans. However, I think where we complement a silver sneakers type solution is our real sort of area we shine is getting non-exercisers to convert to exercising. So it's not go to a gym, take 45-minute Zumba. It might be do 10 minutes seated of pain management for your knee. And over time, that individual is now doing 30 minutes 3 times a week from 10 minutes twice a week. And so that's how you think about longitudinally sort of adding up. And why that's worked for MA plans is it's been not the same users that have always been gym goers before they signed up and then after they've joined. It's tapping into how do we actually bend the cost curve for the harder to engage members historically by giving them something that feels great for them to engage in.
I'm curious. So you've been working with Medicare Advantage folks for a while. Access gets announced as a concept from CMMI. There's a lot of excitement in the industry.
Yeah.
Scanning through the list, I think some of the other big MSK digital health players chose not to participate. They cited financial concerns. How are you seeing the opportunity? Like, talk us through what you're seeing there and how Bold is approaching this model.
Yeah, I can't speak to sort of what other companies' decision processes have been. For us, it makes a ton of sense, and it really naturally fits with what we've already been proving out. So digital first, tech led, right? It's not around synchronous touch points or having, PTs in the loop. It should be a complement, and we've always wanted to be a complement where if you have Bold, maybe you see less PT utilization, or you can manage, reducing wait times for those PT visits. So that idea of, can you predominantly use software, AI-powered software to drive clinical outcomes has been something that MA has historically been more willing to sort of figure out and pay for and invest in primary, secondary prevention. What's great about Access is we've seen for the last few years, we've seen a ton of demand from original Medicare members that have wanted to sign up for Bold. And there just weren't codes, right? There wasn't something that allowed you to more preventatively and without having lots of synchronous touch points with individuals, invest in sort of lifestyle changes or more digital engagement. And so I'd say there's been hundreds of thousands of expressed interest, and we've just said, sorry, unless you're on one of our partner plans, we aren't able to support you. And so last year, actually, we launched the virtual clinic with an eye towards it's time to build for this population. Now, that was a little bit ahead of Access than being announced at the end of last year. And we were thrilled because I think, kudos to CMS right now for saying lifestyle and prevention and things like exercise and nutrition are those levers where if you can really scale them at a population level, we can all see cost reduction. And I think that's just an exciting opportunity for us, but one we've been primed for because we've been through engaging Medicare members and proving those outcomes time and time again, where it's longitudinally showing, fewer inpatient, outpatient doctor's visits, self-reported improvements. And I think that puts us in a great position to say Access is just creating a new way for us to get reimbursed and expand our business to more individuals for doing what we've been doing.
Amanda, it's a fascinating data point on Medicare folks reaching out to you and building the virtual clinic to support them. One of the questions we hear often is about this concept of cost of acquisition and how we're going to drive awareness with folks of the Access model, the costs that folks are going to incur as part of that cost of acquisition. But it almost sounds like you've already kind of cracked that nut in a really interesting way, and it's now just an opportunity to meet that demand. I'd be curious, how are you getting in front of these patient populations today in terms of traditional Medicare? How do you view that changing under Access, and how do you think about that concept of CAC within those two settings?
Yes. Okay. So a lot in that. I think historically, we do partnerships with the health plans and the ACOs that we've worked with to do direct outreach, right, to eligible members. That's really efficient. You get 1 degree away where it's like, I love this program. I really want my friend to do it. Oh, but she's not on the same plan as me. And so we actually get quite a bit of word of mouth or friend-to-friend referrals where it's like, how do you get as ubiquitous as possible? And yes, we want to keep expanding our partnerships on the B2B side, but fundamentally 50% of folks effectively are just on original Medicare. And so we were starting to see more and more, inquiries. In addition, when we do other acquisition channels through, Facebook or YouTube or organic, because we do have a newsletter that we've been sending out for a number of years now. Those individuals have also said, hey, how do I check my eligibility? And when they go through, we kind of are able to say, okay, we're now understanding what the profile is of who's expressed interest, heard about us, but we're not able to serve. And I think that we're really excited with Access launching in a couple of months, that we'll be able to reach back out and say, hey, we're available. And now there's a way for you to engage. Of course, it's, I think this initial iteration will be a more narrow subset. It's, particularly focused on chronic pain. I think the direction that this sets up is more and more broadly, how do you support, more frontline prevention of exercise? Maybe could we engage people before the pain is chronic, or with other types of diagnoses or risk factors? I would say, so we have a lot of built up interest, but I think continuing to be able to say, hey, there's now more people that do those eligibility checks are going to get that instant moment of, oh, great, now I can just go straight in. It's a click away. What I also think is great about Access is it doesn't necessitate that you have that provider referral, but we've done a lot of work with provider groups and some MSSP ACOs, where I expect that will also be an awesome channel for us. And there's always clinicians that are really advocating for exercise already. And as they find out about BOLD, they wonder, how do I refer people in? And it's tough when you say, well, a subset of your patients can use BOLD, but you're going to have, it's unrealistic. They're not going to sort of filter through the funnel. And so being able to take original Medicare members is going to be huge to unlock the power of some of those partnerships as well.
We only have a couple more minutes before we have to let you go. I'd be curious to hear the sort of BOLD philosophy on devices. Like I know for some of the other tracks, it makes a lot of sense to have someone have a blood pressure cuff or a wearable of some sort. What is the interaction mechanism for BOLD? Like, how are people interacting with it, and how are you sort of like measuring some of those data points for Access?
Yeah. So to the first part on devices, we've been device agnostic, and I think more with an eye towards we're in an AI first world now. There's so much data, and there's so much data that doesn't require necessarily a wearable or an additional device, or folks already have those devices. And so you don't necessarily need to be shipping or supplying versus helping them make sense of all the data that those devices are giving them. And that's inclusive of your mobile phone. So there's a ton of activity, gait data, heart rate, sleep data existing on phones that you kind of have with you all of the time. Our primary interaction has been somebody signs up for BOLD. We create a hyper-personalized program for them based on their clinical needs and risk factors, as well as their just personal preferential, right? You have 1,000 people, there's maybe 1,000 different reasons why they want to take that action to change how they're aging. But at the core, it kind of boils down to what are some of the ways you can start building a mind-body connection around how to use exercise to manage pain. How do you rethink about exercise fitting in your life, or movement supporting you in hitting some of these goals? And so the AI and the foundation models our team has built, as well as using off-the-shelf models, is taking all that data, whatever someone's comfortable sharing. And some of it might be, unlocking existing device data. Some of it might just be desire to log new things, and putting that together to have a program that isn't just one-time personalized, but is continuously updated and personalized. And I think that's also where we see longer term behavior change unlock, is you need to be dynamically checking in with someone, because things can change really quickly. And so the question for us is really, how do we make the data make sense for someone and make it actionable for an individual, more than how do we just amass more data that is interesting for our team to look at? We always start with, well, what is someone comfortable with, and how is it going to immediately improve their recommendation, improve their program experience, or improve their sort of accomplishment or sense of progress? Is how do we show people after just a few sessions, they're reporting less pain, or they're doing more sophisticated movement patterns that show that they're seeing their own progress and growth, where I think oftentimes as we age, it's more around preservation and not around progress. And I think that for us has been something that our members tell us is really special about BOLD, is they feel really celebrated that they're unlocking new things as they're engaging.
This has been hugely helpful, Allison. Excuse me, Amanda. Thanks so much for your time today. If folks are interested in learning more about BOLD, or if they're an MSSP, the ACO, and they want to get in touch on how they can get BOLD in the hands of their seniors, what's the best way for them to do that?
you can send a message through LinkedIn to me or through our website, which is agebold.com. And we would love to talk more around how we can support.
Really
Thanks, Amanda.
appreciate your time today.
Always
Thanks
fun
so
chatting
much.
today.
Thanks. Good to see you both.
See ya.
Take care.
You too.
So we had talked last week about access, and we spoke with the Withings folks, and we sort of conceptualized one archetype of a potentially successful access participant as a device company. I thought it was interesting to hear from a device agnostic company that has like a really, I think, strong theory of the case as well.
For sure. I mean, I think we are seeing the angles that I imagine CMI is hearing as well, and it bridges the gap, right? When we hear the reports that, hey, questions about how are these financials going to work, I think those questions are out there for a lot of companies. I think we're also hearing the data points of other companies being like, I think I can find my way through this. Between Bold, we heard it from Neil too a bit earlier in terms of their AI-centric approach. I wouldn't be surprised to see organizations figuring this out over time. So it's cool to hear.
You mentioned silver sneakers before. I wanted you to know I was doing some shoe leather reporting yesterday at dinner and was talking to someone who was
What does that
saying
mean?
that means like I was out on the street. I was talking to folks. I was, like,
yes. Okay.
yes.
Fair.
And I was interviewing some real folks on the ground. And the gentleman I was speaking with was saying that he had chose his United Healthcare Medigap plan for the specific reason that it included a lifetime fitness membership.
I mean, we talked about this with Minnesotans and Blue Cross of Minnesota, and they were picketing the fact that they lost. I mean, it is a big deal. Getting that fitness benefit, right? It's a nice perk, right?
It's a real nice perk. Okay, so you got.
I was gonna transition us to the other
Please do.
hot conversation starter, which in the community, Martin, I flagged. There have been a couple conversations recently about Epic's role in AI adoption, and kind of this growing question of what happens to all the innovative AI tools when Epic comes in and replaces your product with a copy of theirs, and what happens if health systems choose that product, which I think is a really fascinating question. There's a quote in one of the articles this week talking about how health system executives said something along the lines of, if I had to choose between B Epic product and A- startup product, I'm probably choosing the Epic product, which then you layer on top of that, like, yeah, and if the B Epic product costs you $100,000 versus the startup product costs you $1 million, I don't know, Martin, which one of those two things do you think you would choose? Do you want the option to choose between them? How do you process that?
Yeah, this is tough. I mean, I think well, first of all, no, it's not a tough decision. I would go with the cheaper option. Like, if the marginal decrease in quality is, like not I don't value that at $900,000, then yeah, I'm gonna go with the cheaper option. I think that we talk to a lot of folks who are doing really incredibly innovative work at the sort of cutting edge of healthcare innovation.
Mhm.
And the work is hard and it is a slog to get any deal, and these deals take a long time. And so it inherently feels really unfair if someone comes in, like someone like Epic, who has this position and says, okay, well, we can do it for better, faster, and cheaper. And so I get where the complaints come from, but this is how the market works. I sort of am not that sympathetic, I guess, to that criticism. Like, if Epic can make a comparable product at a lower cost, that should probably win. And if your argument is, well, we should pay the startups $1 million, we should, they should go out of their way to pay the startups $1 million versus $100,000. Who's ultimately financing that? I mean, it's like insurance companies and us. Like, that is increasing costs in the healthcare system, something that no one wants.
Yeah. I was trying to make the theory in my head of, okay, so Epic comes in and undercuts, and because of monopolistic behavior, can chase those startups out of the market, which might be a bad thing. Like you should have optionality of higher cost or lower cost. But and so I suppose if Epic always wins, you're worried that eventually the financial backing for startups to compete against Epic is going to go away, and so you're no like you're gonna quash competition in the market over the long term, which I don't know. I guess I could see in theory is an issue, but I think the practical experience in the AI market indicates the opposite is occurring there, right? Which is companies are getting to significant revenue rates faster than ever in the AI market in healthcare. And so if the notion is that Epic is so dominant that there is no opportunity for these businesses, I think they are disproving that theory as we speak, are they not?
Yeah. One of the threads of the conversation that we had in the community was around what do we want from our antitrust regulators? Do we want them to help engineer the lowest like how should the government think about antitrust? And the dominant way that we approach this in the US is consumer welfare. If it is cheaper for something, then we generally allow acquisitions and mergers to happen. It's not the only theory that you could have. You could have a market or a sort of jurisprudence that prioritize competition and innovation and some of these other things. But
Mhm.
there are trade-offs to that, and the trade-offs largely revolve around price. And I think the question we should ask is like, well, if you know the example was $100,000 for Epic solution or $1 million for the startup solution, and I think what we have to wonder is like, why are they so out of proportion for each other? How come Epic is able to do it for so much cheaper? Or was the startup hoping for sort of $900,000 of incremental margin on that, and they're upset that they can't get that?
Yeah. And maybe the argument on cost is a bit of a straw man, right? Maybe the differential isn't that much, but either way, like I fail to see how it's a bad thing that Epic upping its game and coming to product with a market because there's credible alternatives on the market today is a bad thing. Like I don't know. I'm not complaining about that, I suppose. I
Yeah.
see it. If you're an investor in those startups, I get the concern and risk in that, right? Like there's going to be less upside as a result in those models. But if I'm just thinking about healthcare in this country, great.
Yeah. And the conversation was a good one. And for folks who are in the community, I recommend checking it out. Brendan Keeler had a nice riff on interoperability and how that is sort of helps preserve a competitive market. We covered really like a lot of ground there. I think though that, philosophically, you just kind of have to game out like, what do we want and what trade-offs are we willing to accept when it comes to having there be a market? And in general, people tend to prefer cheaper stuff. These are conversations that I think we have in lots of sort of different ways. There's like a certain sort of approach to, or a certain type of thinking that would say like, it is sad that there are not mom and pop 5 and dime stores everywhere, and that they've been displaced by Target and Walmart. And economies of scale mean that Target and Walmart can offer things for cheaper, but people like cheaper stuff.
Yes. It's almost like there should be a theory for evaluating the trade-offs between cost, quality, and access to healthcare that we should talk about from time to time, Martin. We should come up with that one.
This would be the perfect opportunity to debut the Iron Triangle.
Just start
Yes.
wringing that thing away.
Yeah.
Do we want to talk Wiser for a couple minutes before?
Let's talk Wiser for a couple minutes. I think this fits nicely with what I was talking about a little bit in today's op-ed in the Grand Roundup, prior auth. Yes. Incredibly unloved flavor of utilization management. I don't think there's anyone out there defending prior auth except for maybe Jeremy Rees from Humata at the
I'm trying to
moment.
think if there's maybe somebody out there who's defending prior auths, but yes, they are. They are not the popular topic. So CMMI rolled out Wiser program, right? Wiser was bringing prior auths in a very small set of Medicare to market across a handful of states to pilot whether or not it could be used. AI could be used to do prior auths in a more effective way to manage a handful of particularly concerning areas of medical spend. The state of Washington, for whatever reason, it seems to be causing some issues. In particular, we saw a Seattle Times article that we covered a couple weeks back highlighting how there were perceived delays in care as a result of the Wiser rollout. A senator this week from Washington State picked up on the same set of criticism, suggesting that it is increasing wait times in Washington State. AI is denying care, which I think folks in the Wiser model would tell you isn't actually how that model works, but we'll leave that aside for a second. And of course, the criticism that is a political death knell. It is putting profits over patients, Martin. Something I have learned you never want to hear out of a politician's mouth about what you are working on. The thing that makes me curious, so the criticism is isolated to Washington State at the moment, at least that I've seen publicly. I'm going to be fascinated to see how this is rolling out in other states too. I would assume that if there are issues, there is someone in the political spectrum who is looking into this data in their state right now, figuring out, is there a story here I can tell about how the federal government is denying care for my constituents in Medicare and how that is unacceptable from a political perspective?
Yeah, and CMMI is starting to react to these criticisms. So they've delayed implementation on 2 of the CPT codes. I always feel the need, the discourse around this stuff drives me absolutely nuts. Prior auth is not new to original Medicare. We do it today for non-emergency medical transport, and it's a very good thing because we are spending a lot of money on potentially wasteful, fraudulent, or abusive use of non-emergency medical transport. And the CPT code that they talk about when it comes to Wiser, the most often is skin substitutes. And, I go back to Q4 2025, and it was like, or maybe 2024, and it was like $3 billion for original Medicare and skin substitutes versus Medicare Advantage, and it was $300 million. And you're like, it's not just prior auth doing that, but come on.
Mm-hmm.
Come on. All right, I need to read a quick disclaimer before we welcome on our next guest. This live interview and the recording are for informational purposes only. By listening live or accessing the recording, you acknowledge that Bailey & Company makes no warranty, guarantee, or representation as to the accuracy or sufficiency of the information featured. The views, information, or opinions expressed during this conversation series are solely those of individuals involved and do not necessarily reflect those of Bailey & Company. This interview should not be used as a substitute for competent investment advice from a licensed professional in your state and should not be construed as an offer to make or consider any investment or course of action. Kevin, we should probably say that at the top of every of our episodes.
We certainly are not providing competent investment advice as we banter about topics during the day.
Yes. So let me bring Rebecca and Patrick on. Welcome to the show.
Hey guys, thanks for having us.
For sure.
Sorry to throw that wet blanket on top of it at the introduction there.
All good.
No, I
know how it goes.
I think it's probably something we should definitely say when we're opining on Elevance and United Health Group. So Medicarians happened last week, big broker conference. You also recently published a report on the brokerage market. Could you talk to us a little bit about PE activity, basically in the brokerage space, and what were the lessons learned from the sort of last wave of activity and to where we are today?
Sure. Would you like me to cover that, Rebecca?
Rebecca, I can't.
Can you guys hear me?
Yes, I can hear you. I can't hear Rebecca.
Got it. Okay, well, I'll start off here. So I would say that Activity, just kind of keeping this pretty high level because there's a lot to the story here. But activity in the space really started off, I'd say, like in the 2017-18 period. So you had private equity firms investing in Medicare Advantage brokerages. Medicare Advantage was continuing to increase as far as enrollments go. I think they were probably getting to like 20 million members, eclipsing that amount. And then something happened in 2018, 2019. There was a change in accounting practices called 606 accounting. And effectively, it sounds kind of esoteric or just kind of very niche to the space, but it had a really dramatic impact on how these Medicare Advantage brokers accounted for their revenue and EBITDA. And effectively, what it said was that once you place a policy, you need to recognize today when the policy is placed, the expected future cash commissions you're going to collect over the lifetime value of that policy. So that concept, lifetime value, became very, very important in the Medicare Advantage space. So you could see how with certain assumptions, you assume a life of a policy is 3 years, 4 years, 5 years, can have pretty dramatic effects on the revenue and EBITDA that you're recognizing when a policy is placed. So in 2019, this accounting policy was implemented. Medicare Advantage was growing very rapidly. So you had the MCOs looking to acquire a lot of members aggressively. And they were using these Medicare Advantage brokers as a conduit to access those members. About half or maybe more of all members get their Medicare Advantage policy through a broker as opposed to going direct through an MCO. So with this accounting change and this superficial increase in revenue and EBITDA, both private investors, private equity firms, and public markets for a period of time from 2019 to 2021 were valuing these businesses off of their GAAP EBITDA as opposed to their actual cash EBITDA. So you had situations like Go Health that was negative cash flow, negative like cash EBITDA, but had a positive EBITDA of, I don't know, 100 million, 150 million, 200 million, something like that. So for a couple of years, these companies were valued off of that type of revenue and EBITDA. And therefore, private equity firms were aggressively investing in these businesses. And these companies built their model not predicated on long-term cash flows, but predicated on what the market was rewarding companies for, which was GAAP EBITDA, GAAP revenue. So you had a flurry of deals getting done in the 2019 through 21 period. You had Go Health go public at a pretty wild valuation. I think it topped out around 9 or 10 billion market cap after it went from Norwest Equity Partners to Centerbridge in 2019. And then Centerbridge explored both a sale and IPO and ended up IPOing that business at the $10 billion valuation after they had acquired it for $1.5 billion. You had CD&R sell Transact to Willis Group. They bought that for a few hundred million. They sold it to Willis Group, the big broker, for about 1.5 billion. And then a host of other private equity-backed deals and public deals during that time period. So that really characterized the 19 through 2021 time period. And you had a big shift in the marketplace starting in 2022, which we can talk about as well. But most of the private equity and certainly all the public activity was happening during that 2018 through 2021 period. I'll take a pause there. Rebecca, would you add anything to that?
I'm still not
Still
hearing
can't
you.
hear you, Rebecca.
We'll keep going and give you opportunities to chime in again, Rebecca. So one of the other things we were talking about, coming Medicarians, the big annual gathering of brokers in the market, I think it was last week, if I'm correct, timing wise.
That's correct.
Trying to keep my days straight here. So stepping back, it's obviously been a tumultuous few years in the Medicare Advantage market. As I was reading the white paper, there was this interesting sentiment that I saw through it of it could actually be a good time for brokers to lean into that disruption to become more of an indispensable partner for Medicare Advantage organizations as they think about attracting, retaining members, and that dynamic creating a new opportunity for brokerages to win in the market. I'd be curious, assuming I got that sentiment right, feel free to amend it if I missed anything in there.
I think that's right. And Rebecca, can you hear us now? Can we hear you?
I think I think I should be working now. Good.
We got you.
Awesome.
Right.
Yep.
So
You want me to take this one?
I'll hand it off to, so I'm getting a little echo here. Okay,
Yeah, we're
that
getting
seems
your
good.
echo too.
So as I kind of laid out like the PE activity, the public activity back in 19 to 21, really predicated on volume-based enrollments. So volume today, not focused on long-term member retention. I'll hand it up to Rebecca to kind of cover the current status of MA brokers that is very different from what was happening in 19 through 21 during all that activity. But Rebecca, why don't you go ahead?
Yeah. So sorry about the audio issues there. In terms of what we heard out at Medicarians, we spoke with small brokerages, very large players, tech platforms, lead generators, the whole ecosystem. It was a really tough AEP is sort of the headline, right? I mean, we heard groups that came in 20, 30% plus south of where they expected revenue to hit because of some of the actions that carriers took over this AEP. It was an interesting conference in the sense that, everyone there obviously believes in the long-term, tailwinds and value of insurance distribution in Medicare, us included. But there have been some challenges to kind of break down what happened, what folks have seen. For the last 2 years, you've had carriers pulling plans from specific markets, and in some cases pulling out of a market entirely. What happens when one carrier pulls out is that those members go to other plans. The plans don't know what they're inheriting. They don't know what the risk scores are. They sometimes don't want that risk. They get nervous. They may pull plans, or they may decommission, or they just take on members that they may or may not be able to manage and price effectively. So lots of churn in the market. You saw Humana and United and a number of other carriers cut commissions on a large number of plans. Humana terminated roughly a third of their call center contracts. There were regions where, just sort of through a domino effect of carriers making plans non-commissionable, there was effectively no commission available for plans in a given small area. So it was kind of a roulette, depending on where you were concentrated, as to what the effect was. Now, ironically, and this is what we sort of push on in the report, all of this churn means that brokers are more valuable to carriers than ever if they're doing their job in the right way, right? Because carriers need high quality long-term membership. They need, meaning they need folks in the right plans for their medical needs. They need an upfront view as soon as possible of the member, what their health needs are, what their profile is, what their risk looks like. And they need to engage the member and get the member into the right, programs and care management as soon as possible, and not take 9 months, as it often does, for them to sort of work through the carrier systems. So we can talk about this more in a second, but we're seeing brokers both kind of try to right the ship, as there's a lot of choppy waters out there right now, but also kind of leaning into member engagement and quality and compliance as differentiators, as carriers become more and more selective in their broker relationships.
I'd be curious to double click on what do those capabilities look like that are going to distinguish the brokers of the future, the successful brokers of the future, from, I guess, what you would call the older model.
You want to jump in on that, Patrick?
Yeah, so I'd say there's a pretty dramatic juxtaposition between like the brokers of 6 or 7 years ago. They're really predicated on really volume above all else. I mean, they were rewarded for volume. They were not rewarded for retention. They were not rewarded for acquiring the specific members in specific geographies that carriers were looking for. So I think the best brokers today, the ones that we have seen successfully navigate what's been a very tough, like, 3 or 4 years now. You had the accounting change, then the reverberations from that. You had the post-COVID dramatic ramp up in utilization at the healthcare plans. And then with that, them pulling back, as Rebecca just covered. So, and then, marketing dollars have decreased, plans have been decommissioned. It's been a very challenging space over the last couple of years. But there are successful brokers out there. There are ones that have navigated this very choppy water and done it pretty well. And what we're seeing from those are heavy investment in technology. Oftentimes, the top brokers out there are generating most, if not all, of their own leads. So they generate their own leads. They use technology to do that. They track the overall cost of the leads and how effective of policies that those leads produce. Not just did they submit, did they place, did they make it through rapid disenrollment, and then what's their longer term retention. So looking at the overall quality of a policy over a long period of time and the leads that produce that. They focus on long-term member retentions. They're constantly engaging with the members. They submit a policy. There's certain times in the policy lifecycle where they're reaching out to that member, and they're practically engaging with them to keep that member from churning on the plan. Or even if they do churn, they retain that member as part of their brokerage and they place them in a different plan. More solutions to the health plan. So member engagement, benefit activation, that's become really important, not just in becoming a more valuable intermediary for the MCO, the carrier, and the member, but also it allows the broker to further monetize that member and to generate cash revenue off cycle. So not just getting the commission dollars when a policy places, but also monetizing that member in several different ways that happens to make them stickier for both the member and for the carrier. We've also seen this push for product diversification. So oftentimes these brokers would only be focused on Medicare Advantage. We're now seeing brokers focus more on Med Sup, other types of ancillary solutions that this particular member base is looking for: basic wealth solutions, life insurance, final expense, which is basically a form of life insurance, other types of ancillary products, pushing outside of Medicare in the senior audience into ACA as well, so be more of a holistic individual health insurance broker. In other ways to monetize that member throughout their entire life cycle and throughout the year as well too, so that they don't have to be such a seasonal business of hiring a bunch of agents for AEP and then churning them, firing them, riffing them as the AEP period ends and volume goes down. Rebecca, what would you add to that?
Yeah, I just echo the point on diversification. We heard that over and over again. Lots of buzz around final expense. That seems like a pretty frothy theme right now. C-SNP and D-SNP, another sort of product variation that folks are leaning into, and one that you can enroll in on more of a year-round basis. So definitely heard that theme repeated.
The year-round.
One other thing sorry to cut you off there. One other thing I'd add is just this overall view on technology. So AI is, of course, it's a buzz in every part of healthcare. I'm sure other industries too. I think we've seen the early stage deployment of artificial intelligence, particularly around kind of basic things like qualifying someone. Are they eligible for Medicare Advantage or not? There's a couple key questions that even in an AI chatbot can answer before they hand them off to an agent for enrollment. So I think we've seen AI successfully deployed there. AI is successfully deployed in making the agents more productive to a degree. I think we're pretty early innings of this. And I think that the best brokers out there are going to be the ones that really reduce the cost of a lead, per policy. And then also to use AI for better member retention, because the only way to really win out in this game is you need to place people cheaper or policies cheaper. You need to make the agents more productive. The human agent is probably not going to go away anytime soon, but you need to make him or her much more productive. And then focusing on long-term member retention is really the only way to get a steady stream of cash flow. So those are all kind of key parts of the future of the MA broker too. But sorry, I cut you off there.
No, that's all good. I maybe last question for you on my side. I'd be curious one of the things we hear about the brokerage market, it's perceived as one of these middlemen who at times doesn't always play the highest value role that it could in the market, and perhaps gets a negative perception as a result of that. A lot of what I hear you all describing is kind of shifting that mindset to, we are the trusted partner for health plans up front, for helping enroll members in, get them signed up, get those first interactions out of the way. I'd be curious, how often is it discussed? Was that much of a topic out there of that role of the broker, how brokers could be viewed in a more positive light, and kind of this future instantiation of MA with more lifetime value of members and less churn and all that kind of fun stuff?
Yeah, I mean, it's a key question, right? And I think that the industry, having gone through the little roller coaster that it has over the past 5, 6, 7 years, has really come to a place of actually aligning the economic incentives in the industry with that sort of quality and value add, right? The time period that Patrick was describing at the top, where you had, sort of 606 gap revenue and EBITDA being the sort of the thing that brokers traded off of, tended to incentivize just acquire as many members as possible, as quickly as possible, right? And that's shifted now. So I think you have that. You also have AI kind of pushing the industry toward thinking critically about value add. CMS has been pretty open about its interest in AI enabling insurance distribution, right? And there's an RFI that came out in February around that. Various public comments have been made. I don't think anyone sees a near-term future in which CMS has its own team of AI agents selling Medicare Advantage autonomously. Hopefully not. But there is discussion around, well, what, if brokers don't add value, then the carrier really just wants to cut out that expense and is going to in-house as much as possible and AI enable it. And yes, carriers are slow with technology, but there are vendors, and so it just kind of puts a finer point on the value of the broker as a very targeted marketing engine, a very efficient marketing engine. And the real first human contact that an enrollment has, right? Where they're on the phone for 90 minutes plus in the first enrollment call. Go to your medicine cabinet, read me the labels on the jars, type of engagement with the senior. So if you're doing that work right, that's invaluable for a plan. Yeah. And I think that the industry's push now is to double down on that, to sort of stay focused on that quality as there's continued noise in the market, and then start to measure outcomes. We call this out in the report, but that's really something that we haven't gotten to. Brokers are doing this value add work. No one's figured out how to sort of quantify, okay, and so what to the plans in a systematic way. And I think that's the next step that we need to get to.
Yeah,
Patrick,
you'd be surprised.
Sorry,
go. Is that on my end, or I think we got that now?
We're good.
I think the days of the boiler room approach, I think those are over now. Part of that's like a legacy of some of the larger players. So I guess we won't name names here. Really focused on volume. You saw like the Joe Namath TV ads, things like that. High volume, agents that turn very quickly, was overall just a very negative cycle. You talk to some of these top tier brokers out there, the groups that Rebecca and I, spent a lot of time with, sat down with the Medicarians. You may be surprised just how advanced they are from a technology perspective, process perspective. Yeah, there's still a direct consumer angle to this, but it is there's a pretty important sale to the senior or to someone who's on disability and qualified for Medicare. It's an hour, 90-minute conversation. It's a very important decision that this person is making as well. You really need a qualified human to do that. And I think we are continuing to move away from the old perception of boiler room, kind of smile and dial, chop shop type brokers, into much more sophisticated, technology driven, highly scaled, engaged both the member and the carrier level, and adding value to both sides. I think you'll see like the top brokers like continue to evolve like with that model there. We will get away from the days of having this like boiler room type perception for the brokerage industry, because the best players out there like just do not operate in that manner anymore. So we're finally kind of breaking free from that perception.
We have kept you a little bit past time. We really appreciate the overview, the update from Medicarians. Where can people who want to learn more about this space find the report that you all put together?
We can share a link to our website, and you can download it there. We'll just take your email in exchange.
Great. Well, we will link to that in the show notes. Thank you both so much for your time today. Really appreciate it, and excited to have you back soon.
Good seeing you both. Thanks for the time.
All right,
Thank you.
Yes.
Martin, it sounds like Joe Namath is going to need to find a new revenue stream here in the not too distant future.
One of the quirks of this job is I often am at the gym in the sort of mid-afternoon after we do the show, and I see a lot of, when I'm running on the treadmill, a lot of Medicare Advantage commercials.
They might change coming up.
They might be changing.
I mean, it is a entirely logical premise to me that we are undervaluing the role of a broker conceptually when done right, and that as plans, we hear Humana all the time talking about lifetime value of members. As plans are rethinking this, it does seem like there is an opportunity to get in front of that, and perhaps organizations have been getting in front of that, and that is where you really want to be. But it seems like this is where the market's headed. So cool to hear that update.
Cool to hear that update. We are almost at the top of the hour. It has been a pleasure chatting with you and all of our guests, Kevin. We will see you next week on Monday, May 4th.
It's already May. Crazy.
Already
see you
May.
next week, Martin.
All right. Bye-bye.
Bye.